So to talk about tools and quality improvement tools and methods, let's get started on that. There are fundamentally, fundamentally, when we talk about improvement models or improvement methods that people use, when you're improving anything, whether it's personal or work-related, bottom line, there are three things that need to happen for improvement to occur, right? We need will. We need will from people to want to do what it takes to change to some new system. So it does take that. It takes ideas on which to base the design of the new system. And I think in healthcare, my experience is we certainly don't lack for ideas and for things that we can change. And there's a lot of people who want to do the right thing. So I find that the will is there, but year after year, time after time, I find that the hardest piece, but the necessary piece, is then taking those ideas and all of that will and actually executing the ideas. So execution, as I quiz people around the world about this and ask them, they will time and time again say, it's executing that's so hard. And bottom line is, that's why we use an improvement method or an improvement model. Now on the slide, there are lots of roadmaps for improvement. There are lots of ways to do this. And I think everyone's looking for that perfect roadmap. And I will say to you, I don't think there is a perfect roadmap. I think we have preferences. Everybody has preferences. And here's a bunch of them that I've seen, and perhaps you all have as well. We've got, and particularly I think of late, we see a lot of lean, right, which makes a lot of sense because lean is, and some of the lean tools are especially helpful in flow and standardization and flow, which a lot of our projects are focused on, so that makes sense. Or Lean Six Sigma, as systems work to make their processes more and more reliable, shoot for zero defects. Again, that they call it DMAIC, define, measure, analyze, improve, control. So I've seen some of that. But today, and those are fine. There is no perfect roadmap, and some of you may use one or the other of these, and it doesn't really matter. What matters most is that we have an improvement model that works for you and that helps you achieve, as Jessica was talking about the importance of the aim, helps you achieve your aim. So for the purposes of this call, and because we can't talk about all of them, I am going to focus on that middle one, which is the model for improvement. But and you'll see a bit about that in a second. But again, irregardless of what improvement model you're using, the underlying principles, if you look into them, are similar as well. So here are four of them, again, on the screen. Underlying principles or strategies that if you dig deeply enough into any of these models, you'll find them. It's first of all, in any improvement, and as perhaps you're in a position to support improvement in the practices, we want to make sure, right, that we're focusing on systems and not people. Not bad people, bad systems. So any work is organized around optimizing the system. And because systems are so complex, we break them down into processes. And that's why you hear process improvement. Because the harder you push on this big old system, the harder it pushes back. So we break them into processes. The patient voice is the customer of our processes is vital, making sure that absolutely we can improve processes for ourselves, the healthcare provider, but we don't want to do that and suboptimize certainly the patient experience. So it's keeping that customer front and center. Leadership support is key. Jessica already mentioned that, and teams are, as she also mentioned, very critical to the work. So that's one thing that's common across all these models, and I like to look at the commonalities versus the differences. Is first of all, they focus on bad systems, not bad people. there is in each one of them a need and a focus on having frequent and ongoing measurement, but measurement for learning and for improving, not measurement for judgment, not measurement for research, but measurement for improvement. Every model has this underlying, we know that all improvement requires change, and so that's why we have these models, to help us as best as we can make sure that our changes result in improvement from the get-go. And finally, this one thing that made it through all of these passes, if you noticed in that prior picture, all of these passes at different types of models, the one standing thing that's made every cut, if you will, is the plan, do, study, act cycle. It's that idea of we take things, we take interventions, and we test them iteratively and preferably on a small scale first, using plan, do, study, act cycles. So I think, you know, the good news is there are lots of models that can help us close the gap in care and improve our care. And the other good news is there's lots of commonalities between all of them. But as I said, we will talk about the model for improvement because it is, in the evolution of models, one of the more recent, actually the most recent. It was developed by associates in process improvement, and some people think it's the IHI's model, but it was made famous by the Institute for Healthcare Improvement, and we use it, but it was actually developed by associates in process improvement, and it's kind of because it's like the Swiss Army knife. It can do everything. And then at the same time, it's quite simple. It's three questions, three fundamental questions. And again, they can be addressed in any order, although I usually will start with the first one. And then this, like I said, the plan, do, study, act cycle. And here's what it looks like. Some of you may be familiar with this already and perhaps use it. But the three fundamental questions that we ask ourselves before we go out and start testing are, first of all, to Jessica's earlier comment about the importance of a vision, we ask the same thing for improvement projects. What is it we're trying to accomplish? And perhaps even more than that, why is it important to work on now? Some conversation about that vision and about where it is we're heading, so we can get alignment around that. The second question is, how will we know? How will we know the changes and improvements? I can remember working with teams many, many years ago, and we'd have team meeting after team meeting, and months later, we would be adjourning our team, and the question would come, well, how do you know you improved? Well, we think things have gotten really a lot better. We really feel. So it's a lot of we think, we feel, it seems, and we weren't doing quite as good a job, or maybe a good job at all, with making sure that we had measures early on that we could watch and learn from, and know that the changes that we were making were resulting in improvement, or that they weren't. We had no way to recalibrate. That's a very important second question. We'll talk more about data in a bit. And then finally, and after we've answered those, we engage in looking for what changes can we now make that will result in improvement. And underneath that, of course, is the PDSA cycle, which is the little engine that we are constantly doing iterative testing of these interventions and learning from those tests. So it's almost a disservice to have just one PDSA bubble under those questions, because in reality, we're doing many of those at the same time. So that is a bit about the overarching questions in PDSA, and now we'll jump into a little bit more detail about what goes on in these questions. So Jessica, back to you.
So in looking at, you know, the science of improvement, again, we've kind of already touched upon the forming of the team and the need to include the right people on that team. You know, I think of various projects that I've been on, and really truly the most successful right from the beginning have the people that they need at the table to begin with. So really thinking out that process is so important. You know, setting the aims, like Sue alluded to, you know, we want the aims, we really want to think about when you're studying that, what's that big picture, you know, for what population are you looking at, how many, how are you going to attain this, and then it's so important to put some time on that, right? So we want it to be time specific, measurable, and define that specific population of patients or a system or what's going to be affected. And then we do that by looking at different measures. And so most commonly, what I have seen, and Sue, again, feel free to jump in on this, is outcome measures, process measures, and balancing measures. So when we think of outcome, you know, measures, I think that really think of it as that high level, that quality and cost targets that you're looking for, you know, clinical or financial outcomes. And so examples of this would be like mortality rates, readmission rates, surgical site infection rates. I'm trying to think of some other things. So those are some examples of some outcome measures. Now, process measures are really looking at the evidence-based best practices to really look at improvement efforts. So what's the process? You know, what are the measures? What are the steps that lead in this process to either negatively or positively affect this outcome measure? So really looking at the process and how we do that. And then the balance measures, if useful, are kind of one to balance the other. So in other words, if you're making an improvement, you're also making sure that you're not negatively affecting something else. So for instance, one example I can think of is like a length of stay, you know, after you have a baby in the hospital. So, you know, as a hospital or a system or a floor, however you want to look at it, you're looking at that length of stay and you want to minimize that. But at the same time, we don't want to affect patient satisfaction. So a balancing measure would say, okay, we're going to look at our length of stay after the delivery, but we also want to make sure that that patient feels well supported and ready to go home and isn't feeling like we're kind of, you know, scooping her up and heading her home before she's ready. So that's a kind of an example of balancing measures. So again, data is truly a key component of QI work. And one of the things that I have found in this work to be so helpful is to truly take the time to validate your data. You know, I've been in projects where, again, you know, we think we're clear on our numerators, and our denominators, and really looking at different screening rates or populations. And then we're in it like 3 months, and then we realize, you know, maybe the EHR, maybe we put that in, how do we want to do that? So really important to take that time to, again, like I talked about before, and really setting up whatever QI project that you're doing. And I have just found that to be invaluable, to take that time, make sure you're pulling it the way you want, your EHR is working the way that you want it to work, you're identifying that patient population that you want to work with, and that the EHR is pulling it correctly from that EHR. And a starting point with QI work and data is empanelment. So, you know, tying patients to providers, clinical teams, you know, there's lots of research that's been done on that and improving clinical outcomes. And there's just another whole piece I could talk about just within empanelment, but so important to do that, especially as we're looking at, you know, this quadruple aim and population health. You really need to be able to empanel patients to be able to look at that and how are you caring for all your diabetics in your panel as a whole and those kinds of things. You know, PCMH and patient-centered medical home and meaningful use truly connect technology and quality together. And then making sure that your team understands the difference between guidelines and measures. Again, clinical guidelines, clinical practice, and then measures on how we're actually measuring the work that we're doing. Looking at processes and outcomes, and then practice level data. You know, again, that can be system-wide data, it can be practice level, and it can be provider level as well. Again, it needs to be presented so everyone can understand. You know, don't assume, and with the next slide, Sue, that if you're putting up run charts or different things like that, that everyone is going to understand that. You know, take that time to explain this. Again, the whole goal of this is to get everybody on board and to get in and really feel involved in this project. And you really want to again, take that time to explain what they're looking at. And this is just a couple of examples. You know, you've all seen the charts with multicolors. You can do maps. You can do all kinds of different ways to present data. Baseline assessments and ongoing evaluation. This is another key component I have found in this practice of quality improvement. And I I really, again, encourage you that data validation piece, and this is almost like step 2, is taking the time to do a baseline assessment on whatever you're looking at. And we're going to briefly get into some QI tools in a minute on how to do that. But one of the things, too, is looking at a baseline assessment to really identify the strengths and opportunities that you have. I cannot tell you how many times I've been at a practice and doing a baseline assessment, and many times we're looking at process and we're using maybe a, some process mapping or something, and we're looking at it in what the thought is of how that's supposed to go and what the reality of how that process is actually working is typically 2 different things. So I just find it's invaluable. It really, like Sue was alluded to the PTSA cycles that she's going to jump into, but it really provides that framework to figure out what they want to start working on. Again, assessing at the start of the project is critical, and again, measuring the factors, that making sure that the assessment that you create is really what you're looking for, and then making sure to reassess. And the other piece I didn't really cover on that is really one of the things that we've done is really taking the time to do surveys too, looking at your staff and your clinical team and the providers and maybe some barriers or beliefs they have around something that you want to introduce. So one example is we worked on fit testing on a colorectal cancer learning collaborative, and we sent out a survey asking providers and clinical staff a little bit about their knowledge about fit testing and about reasons why maybe they don't feel that they're ordering it for their patients. And it was really eye-opening, and we were able to take that and then really tailor the education to where it was needed. So that was a really helpful tool. So again, just quickly, I'm going to let Sue kind of jump into this next piece a little bit, and then we're going to start getting into a few tools, and then questions and answers from there. So Sue, I'll let you.
Thanks, Jessica. So, we've talked about the first question, right? What is it? So after we would answer the question, what is it we're trying to accomplish? How will we know? And we have our measures. It's then that we'd move to the third, which is what changes can we make that will result in improvement? And they can come from a number of sources. And actually, Jessica is going to show you a tool that we use. It's called a driver diagram to actually organize some of our theories about those changes and how to set those up. But I think the important thing is it's forging ahead with thinking about that after we've answered, after we have a clear aim of what it is we want to accomplish and of our measures. And then we can use the PDSA, the Plan, Do, Study, Act cycle, to test those changes in our real world settings. And I'll talk about PDSAs in a bit. You also can use PDSAs to not just test on a small scale, but also to implement your changes after the testing has shown itself to be successful and you want to scale up. So it's a very, again, it's a simple but robust tool and way to think about improvement. And then, of course, we'd move to spread it organizationally, but not after first testing and then implementing.